The second talk is Dr. Shweta Tripathi to speak on pathophysiology of optic nerve cupping from glaucoma, retinal and neurological conditions. Dr. Shweta Tripathi is a senior consultant at the Indira Gandhi Eye Hospital in Lucknow. Over to you.
Can I get my slides? So a very good morning to all. Thank you, Chandrima ma'am, for having me as a part of the IC, and thank you AIOS for giving me this opportunity. Again, on my laptop, my slide deck is not there. On my laptop, I'm not able to access my slide deck. Usme jao? Sorry for that glitch. So when we talk about the pathophysiology, my topic assigned is we are going to talk about the pathophysiology of the cupping when it comes to glaucoma and other non-glaucomatous causes as well. So when we talk about this, the first thing, again the slide deck is not moving. The IT team, slide deck is not moving. Yes. So with that, we go back into the history in 1857, when the first association between the optic nerve head and glaucoma was established. And till then, after that particular timing, there is no looking back till 1973, when the association of RNFL defect was correlated with glaucoma. Having said that, cupping is what? We all know that whenever the cup disc ratio is changed and increased, we say that it's cupping. Though it's a very well synonym going well with glaucoma, but always it's not the pathognomic of glaucoma. Having said that, when we talk about the non-glaucomatous cupping, there are various challenges, especially when we come to the pallor. As study done by Toby et al. Showed that 44% of the eyes with non-glaucomatous optic atrophy were misdiagnosed. And the major challenge coming back to, again, to differentiate between a glaucomatous cupping and a pale disc. So the key points which I would be sharing here would be the non-glaucomatous cupping do have different visual manifestations. The visual field should be looked carefully at. The history of presenting illness, high intraocular pressure, and the details of old records should always be looked for. So when we start describing glaucoma, it comes as a progressive loss of the ganglion cells, which does happen because of the glutamate-induced excitotoxicity and the nitric oxide neurotoxicity. Everything leading to apoptosis and further leading to the retinal ganglion cell death. So before we go into the detailed pathophysiology, let's understand the optic nerve head, the optic disc, which is divided into three zones: the laminar, prelaminar, and the retrolaminar. And 1.2 to 2 million of retinal ganglion cell axons, they do converge and exit the eye through the inner Brooks membrane opening and the outer part of the neural canal, which is the scleral part. Now, once they go out of the scleral part, they do meet with the connective tissue beams, which are known as lamina cribrosa, which are nothing else but a combination of connective tissue, capillaries, and the astrocytes. And if we want to think about the pink color of that optic disc which is there, that's because of the central retinal vessel entering the eye, and the capillaries, which are basically a branch of the posterior ciliary arteries. The hue from the capillaries impart a pink color to the optic nerve head. So if we want to understand, because only if we understand the blood supply to the axon, we can very well understand the pathophysiology of glaucoma. So when we talk about the blood supply to the axon, first thing is that the primary site of the RGC axon insult in glaucoma is within the lamina cribrosa. So if we see carefully here, the diffusion of the nutrients goes across the endothelial and pericyte basement membrane, goes through the extracellular matrix of the lamina beam, and then from there it goes to the basement membranes of the astrocyte. And if you see in the top picture, if you see it carefully, these are the vertical lines depicting the axons, and from here it goes and gives the nutrition to the axons. So any reason by which these axons, the nutrition supply is going to be hampered, definitely they are going to lead to axonal cell death, which further progresses into glaucoma. So having said that, the auto-regulation of the ONH, which is really important when we talk about the glaucoma disease onset or the disease progression. So the auto-regulation basically exists between the non-IOP related factors and the IOP-induced factors. In non-IOP, we all know it's systemic BP fluctuation or the vasospasm. And in the IOP-induced factors, it is the compression of these posterior ciliary arteries, which are when passing through the neural part or the scleral part due to any kind of scleral stress or a strain, will definitely lead to a compromised blood flow, thus hampering the supply to the axons, leading to the death. Now coming to the cupping, understanding about it. The cupping can be broadly divided into two groups. First would be the prelaminar or the shallow form of cupping, and the second would be the deep form of cupping. Having said that, again going back and saying and emphasizing on the same line again as from where I started, that cupping is a manifestation of the neuropathy of glaucoma. It's not the neuropathy itself. Let us see how. So this is a three-dimension reconstructed image of the ONH, where the green line you see, it's a zero reference plane. Beneath it, it's a lamina cribrosa. So from here, there is a connective tissue, and from here, there is a Bowman's membrane, Brooks membrane opening. This is the shallow form of the cupping, and this is the deep form of the cupping. If you look at the shallow form of cupping and we try to understand the pathophysiology, here, anterior to the lamina cribrosa, it's only the loss of the neural cells which is happening. There is no deformation of the connective tissue actually which is happening, which is all anterior to the lamina cribrosa. But here when we go and we see that here there is a deformation and disfigurement of the connective tissue which is associated with the lamina cribrosa, and this is how you see the area enlarges and the excavation happens and the cupping occurs. So all in all, we can say that whatever the reason may be, the final excavation or the damage to the optic nerve head is because of the IOP related changes only happening. Maybe the primary insult be inflammation or ischemia or whatever it may be. Now talking about the glaucomatous cupping, as I very much said in the very beginning, that always whenever we are talking about glaucomatous cupping, it has to be strongly correlated with the visual field changes which are happening. Now, if we look at this picture, this is a normal ONH, and when you see at the disc pallor, this is something like this. So if you see, though it's a very advanced pallor, but yes, pallor is one thing which needs to be always differentiated from the cupping, because the non-glaucomatous cupping, they do manifest majority of the times in the form of pallor. Now, this is a 2-second pause for the audience that what is this? If we go for this, we have been talking about the glaucomatous and the non-glaucomatous cupping. What do we think about it? Most commonly known as cupping only, but actually it is a physiological cupping, which is seen in the majority of the time in the myopic eyes. Different variants of the ONH, that is tilted disc with the crescent, or a peripapillary halo. So when you talk about the 5 rules for evaluation of the optic disc, if you follow these rules, you are never going to get confused with a glaucomatous or a non-glaucomatous cupping. Now coming to the non-glaucomatous mascuroides, they do manifest as the cupping. So if you talk about this pituitary adenoma, which has got a suprasellar extension, manifesting here as a form of cupping. So if you don't go into the details, you see simply on the OCT, you see that there is a RNFL loss, there is a ganglion cell loss, and you will land up seeing that it's a unilateral glaucoma. Again, a point taken from here clinically would be, always be suspicious about the unilateral glaucomas, especially the primary glaucomas, if you think it's a primary. Then the differentiating point would be here that in these cases, the central vision and the color vision is definitely going to be affected in the very beginning instead of the glaucomatous cupping, where the central vision is retained till last. Now, any mismatch between the two things will definitely warrant for a MRI or neuroimaging to be done. Again, going to one of the mascuroides, that is, you can see that there is a, now here you see the picture, it's a bilateral manifestation of the temporal pallor. So it's basically a toxic case, toxic amblyopia case, where there is a toxic neuropathy, I can say, toxic neuropathy, where there is a temporal pallor, bilaterally symmetrical pallor. So if you want to differentiate, because all these things are any kind of vitamin deficiency or toxic neuropathy, will definitely lead to this kind of disc manifestation. Being a mitochondrial dysfunction, the manifestation is again going to be affecting the central vision. So always and go for the RAPD, central vision, and the color vision. Last but not the least would be the inflammation, seeing this eye on the, this was a pre-optic neuritis. Post-optic neuritis eye, you see that the disc had an insult and now it has gone into the pallor form, where if you not examine and evaluate correctly, you see that there is a cupping, increased cup disc ratio, but actually it's a secondary insult which has happened to the ONH. So in this wide list of the mascuroides, the colobomatous cupping cannot be ruled out, cannot be left alone. And at the last, I would conclude saying that the algorithm for the differential diagnosis of a glaucomatous and a non-glaucomatous cupping would be the patient's history, the medical history, family history, visual function, neuroimaging, and blood investigations as well. So the take-home message would be diagnosis is seen in totality. Thank you very much.
Thank you very much, Dr. Shweta, for that very illuminating talk.